I'm working as an assistant professor at Aga Khan University Hospital, and I'm the moderator of the session. Our session is based on dermatosurgery and aesthetic dermatology. So I would first like to invite the panelists, the chair of the session, General Zafar Iqbal Sheikh, who's the president of Pakistan Association of Dermatologists and the Dean of Dermatology in CPSP. He has worked as the head of the Department of Dermatology and professor at Military Hospital, Rawalpindi. Sir. Next, I would like to invite Dr. Badar Dhanani, who is one of the most senior dermatologists in Karachi. He is the patron of this 37th PADCON, and he has busy clinics at DHA and OMI Hospital in Karachi. Now, I would like to invite Professor Naseema Kapadia. Madam, with over 30 years of experience in dermatology, she is the head of the department and professor of dermatology at the Karachi Medical and Dental College and Abbasi Shaheed Hospital, and she has always been a very esteemed faculty and examiner at CPSP. Now I would like to invite Dr. Zishan Parvez. Everyone is aware of Dr. Zishan Parvez. He is the executive member of Pakistan Association of Dermatologists, representing the federal areas, and is working as a consultant at NESCOM Hospital in Islamabad. Dr. Zishan. The first talk is by Dr. Babar Rao on diagnostics and therapeutic innovation in dermatology. He is the professor of dermatology and pathology at Rutgers Robert Wood Johnson Medical School, and an adjunct associate professor at Cornell Medical School and director of Rao Dermatology. It's a video link session, so Dr. Rao, can you hear us?
Yes, I can. Thank you. Thank you.
Welcome.
Thank you, PAD, and thank you, Pakistani Association of Dermatologists, for giving me this opportunity to talk, especially via internet. I'm sorry I'm not there for some other commitments, but thank you, Dr. Zafar, Dr. Badar, Dr. Kabadia, and especially actually Rabia, who succeeded to recruit me at midnight in New York. My introduction was kind, and I will get started. And before I go into any details, my lecture tonight have one conflict of interest, which is a company which makes these confocal microscopes. I'm their consultant, so I must declare that. Now, this is where I started from. Some of you, if you know Khanewal, close to that there is a small town called Kabirwala. Further that there is a small village called Madisau, and this is, I got it from Google Map. That's where I started from as a child. And now this is where I live in New York City in Manhattan. One of my offices is here in this building. I live also here. And I'm thankful to really Pakistan for this journey, because if you all remember, when we were medical students, our tuition fee was almost free. And if we didn't have books, even they were given free by my medical school. I got many of my books free at that time because I couldn't afford it. So thank you for Pakistan for educating me free, because it is very expensive in these countries. Now, to get to that journey where I am now in my professional and social life, I started from Muslim Model High School, Lahore, on the left top. Then I went to Government College, Lahore, and then I did most of my training in Rawalpindi Medical College. And this is now a Department of Dermatology in Rawalpindi Medical University now. At that time, we were only two of us, the Mizuddin right behind me, one of my teacher, and Kadus Bhatt, who really played a major role in establishing the Department of Dermatology now in Pindi. These are some of my teachers. General Mehboob, most of you know, a thorough gentleman who taught me how to behave, how to be organized. Dr. Ashfaq, who made dermatology even serious. I thought it was a very superficial specialty, but he made it very serious, and it is serious. And then obviously Dr. Shabir, who was a thorough gentleman. I sat with him a few times and learned a lot from him. And Tamizuddin, who was my registrar or medical officer at that time, I started learning from him. Now, I am where I am professionally and socially and economically, and I'm very thankful to God and everybody else who helped me. And to give back to whatever I could give back to my country where I'm from, I have done few projects with some of my other friends from my medical school. This is a girls' school. We started about 7 years ago in a small town outside Bakhar or Darya. And we started with one girl, and now we have 180 girls there, and in 7th grade we are hoping to take it to high school level soon, hopefully. I have also contributed and led a project to start a burn center in Holy Family Hospital in Pindi, which was started with our efforts, and now it's taken over by Punjab government, and it's a very successful place. And then a dialysis center at the same place, which is now serves thousands of people. So we try to do as much as we can in our business. Should I do biopsy, or I don't know what to do? Then there are magnifying glasses, something very popular nowadays called dermatoscope. If you put the dermatoscope on lesion, you get about 10-15 times magnification, and you can see in the lesions more than just with naked eye. And then there are machines like this, which I'll talk a lot tonight, something called Confocal Microscopy, which is basically you put it on the skin without cutting, you can see cells, and you can diagnose and manage things. Now, by using that confocal scope in our lab with collaboration from another partner from California, Gene and his team, we have been able to do some wonderful work. What I'm showing you is, believe me or not, these are multinucleated giant cells from a herpes infection, which we picked it non-invasively with confocal microscopy, and then we are showing that giant cells in 3D, which you have never seen before, because this is the first time I'm presenting this work. And basically, we can see cells without cutting in things like herpes and other inflammations. Moving forward, other than just looking at the cells, now there are technologies. One of them we are working, this is our paper, is called a terahertz spectroscopy, where we can already look at the lesion and tell is it benign or not benign, and in future we'll be presenting more work with this technology. So going back to, I started with naked eye. Naked eye I cannot teach you, because you guys are, most of you know more than me clinically. So I'll skip that part, but I'll go to a little bit into dermoscopy. And we published many years ago, there are many ways to use dermoscopy, but our formula is called a simple and practical dermoscopy. And in that, basically, the formula is dependent on if the lesions you're looking at, are they known benign patterns or there are known malignant patterns. For example, if you see these patterns, obviously we can't teach whole dermoscopy in this lecture, but just an intro. So if you're looking at these patterns on the left, on the side, then you don't need to biopsy. And these are examples of these patterns. If it's a network pattern, globular pattern, homogeneous blue pattern, a red lacuna pattern as a cyst, comedon-like structures, or just patchy network, you don't need to biopsy. These are benign. On the other hand, if you see patterns which are like this this series, then you will biopsy. And here are the pattern. If you see any of these patterns which have atypical pigment network, multiple color, regressions, telangiectasia, dotted vessels, you'll biopsy. So using dermoscopy, we can already tell benign from not benign, and then dermoscopy is also helping in approaching inflammations, such as sometimes rosacea on the face could be difficult to separate from seborrheic dermatitis, from psoriasis, from lupus, or any other red condition. But by putting a dermatoscopy, sometimes you can see these polygonal vessels, which are specific for rosacea. Next one is psoriasis. If you see regular red dots, then it will be psoriasis. If you see these yellow scale and dotted vessels which are not regular, that will be eczema. And if you see become stria, by the way, you can clinically also see, but dermoscopy will see it more. So you can separate this condition based on dermoscopy. You can also look at hair and then basically separate various conditions just with dermoscopy, such as in alopecia areata, you'll see yellow dot, black dots, and exclamation marks. In tinea, you can see this corkscrew hair or comma-shaped hair. In androgenetic alopecia, you will see some perifollicular pigmentation and brown dots, and if it's lichen planopilaris, you'll see some peritubular cast, or which is shown here with a black arrow. So idea tonight is not really I'm teaching you whole dermoscopy, but just to introduce, like using dermoscopy, your diagnostic accuracy can get better. So here then there is this paper where they show a naked eye versus dermoscopy, especially in neoplastic lesion, your diagnostic accuracy improves, and rightfully so. So in United States, at least I know, now more than 50% of the people, they use dermoscopy for pigmented lesions. So going on to next one, which is my favorite and my interest in dermatology right now, is confocal microscopy. I introduced in the beginning. And confocal microscopy, basically you see images horizontally, like instead of vertically, like in histology. And you can actually, I'm going to skip some of these pictures and go to next one. So it's basically a little probe which you'll put on the skin, and you will start seeing black and white images. And then once you have an image like pathology, you can sign those cases from anywhere from your laptop or your computer, because they're transferred via a secure net to you. And then these are my slides on confocal, which obviously I diagnose on daily basis. And you'll have a clinical information, and you have black and white images.